Nagamani, and she has an important topic. She has a topic very interesting of evaluating myocardial ischemia in women, and she being herself a cardiology professor and if I say, lady, please don't mistake me for saying this, that what she has got to say when she evaluates myocardial ischemia in women, what kind of tests you would like to choose beyond an electrocardiogram. If the electrocardiogram is normal, what else next? Thank you so much. She is Professor of Cardiology at the prestigious Sri Jayadeva Institute of Cardiovascular Sciences and Research. Ma'am, go ahead please.
I would like to thank Dr. Nagaraj Desai and Dr. Prabhakar. As we know, cardiovascular disease is the leading cause of death in women, more than the cancers. And while we have seen a decrease in cardiovascular mortality in men, but in the women, if you look at this trend, there is a new female majority. The cardiovascular death has increased in men. This triggered off various studies, and WISE was the main study. This study was basically to recognize and take action to look at this. This is popularly called as Endel syndrome, a term coined by Dr. Bernardine Healy. What they noticed was when women had obstructive CAD, then only she gets the appropriate treatment. So basically this syndrome describes the gender inequality in IST management approaches. So is CAD different in men as compared to women? And in women, what we see is the difference in the prevalent symptoms and pathophysiology. And the classification of typical angina, if you apply, you are going to miss IHD in around 65% of women with CAD. So this is what the WISE study told. The plaque erosions are more common. You have more atypical symptoms in women. And if we look at the normal and the non-obstructive coronary artery disease, up to 50 to 60% of women with coronary artery disease have either no obstruction or a non-obstructive disease. But despite this, they have higher rates of myocardial ischemia and mortality. And they have greater symptom burden and more functional disability. So they have more times higher chance of rehospitalization and angiograms. Why this happens? This is multiple factors are there. They have thinner myocardial walls, smaller coronary arteries, lower vasomotor tone. Coronary remodeling also is different. They have more of plaque erosion as compared to plaque rupture and more of non-obstructive coronary artery disease. So this atypical presentation leads to underdiagnosis, delayed diagnosis and under-treatment. So this triggered off the WISE study. WISE study was a 2-decade-old study, 4-center study. They concluded that up to 50% of women who undergo clinically indicated angiogram have either no or non-obstructive CAD. But their risk of major cardiovascular event is more. So when they followed up, if they had myocardial ischemia, they carried poorer prognosis as compared to women with non-obstructive CAD who had no myocardial ischemia. So we need to have certain tests to define whether patients have myocardial ischemia or not. So what are the pathophysiologies? As we know, when there is no obstructive disease, is obviously the vasomotor dysfunction. Either it could be vasospasm or a microvascular dysfunction, or they have higher lipid content, microembolization, all this has been. And when they are 50 years of age, so they fit into postmenopausal age group, they have higher comorbidities and they are classified as intermediate risk. So with respect to this, there is these entities which are described. This is MINOCA, what we call as MI with non-obstructive CAD. INOCA is ischemia with no obstructive CAD, and ANOCA. These terminologies have come in the last 2 to 3 years, but the underlying pathology is challenging to diagnose. And is it a missed opportunity for us to accurately diagnose and treat underlying disease? So when it comes to that, when you have no obstruction or less than 50% obstruction, we are looking at either plaque disruption, coronary thrombosis or embolism, or it could be SCAD, or it could be myocardial disorders, or it could be just MI mimics like Takotsubo cardiomyopathy or other cardiomyopathies or myocarditis itself. There can be myocardial bridge as well when they have clean coronaries, or it could be just simple slow flow. So American Heart Association in 2014, they updated a consensus statement regarding non-invasive testing. Women more than 70 years fit into high risk, but between 50 and 70 they are sort of intermediate risk. When they have low intermediate risk or intermediate risk, and if their ECG is normal and if they are capable of exercising, they should undergo a treadmill test. So there is still role for exercise treadmill test. If they have intermediate risk or high risk, preferable, or if they have an abnormal ECG with this kind of risk factors, stress imaging or CT coronary angiogram is the go. If they have stable symptoms, you can still stick on to stress imaging or CT coronary angiogram. Of course, if there is unstable symptoms, we will end up doing invasive coronary angiogram. So ECG, as we know, we have some non-specific STT changes and T inversions in V1 to V3, which is common. If we come to exercise stress test, as we know, sensitivity and specificity both are low in women, but it is still indicated if the ST segment response alone is used, the sensitivity is less. But if we include the exercise duration and the exercise capacity, the sensitivity and the specificity both increase. So women who achieve less than 5 minutes are at increased risk of a cardiovascular event. So there are various studies which have shown that exercise stress test is still useful. And this is a major study which reinforced the utility of exercise stress test as an initial diagnostic strategy in low risk or intermediate risk. But if they have high risk, we go on to stress imaging. Stress echo has improved sensitivity and specificity as compared to exercise stress test. It is widely available, there is no radiation, and we get structural information as well, and nowadays we can combine it with strain rate imaging, and it is also applicable in pregnancy where other modalities we cannot use. Of course, it depends on the image quality and interpreter variability. Next comes the myocardial perfusion imaging SPECT. It has number of sex-specific challenges if you look at this. Because women have smaller sized heart than men, the sensitivity is less. There is variable breast attenuation, it can give rise to false positive studies. There is reduced sensitivity because of severe multivessel disease or microvascular disease, and of course there is high radiation exposure. But suppose MPI SPECT comes as normal, the annual event rate is very low. So it is very, very important to know this. But if it is falsely positive, then patient may end up getting a label as a ischemic heart disease patient. Then the positron emission tomography, it has several advantages. It gives us both structural and functional information. It has higher spatial resolution. Diagnostic accuracy is high, and we can quantify the myocardial blood flow and coronary flow reserve. And it can also define clot morphology. There are various advantages, but the disadvantage is the cost and the availability. But the accuracy and reproducibility is very well validated with PET. So cardiac MRI has advantages because it is less sensitive to the technical limitations of all other modalities. Breast tissue, obesity or lung disease doesn't interfere with the interpretation. And in women with ACS and normal coronary arteries, subendocardial ischemia is the most common finding. And in a sub-study, it has been shown that women with non-obstructive CAD with abnormal stress-induced CMR had an increase in adverse cardiovascular event. So it's a good idea to do a cardiac MRI if you demonstrate a normal coronary or a less than 50% stenosis. And it is also helpful when you have myocardial injury without evidence of obstructive CAD, you can pick up the other diagnosis. Identification of the underlying etiology is important for risk stratification and decision making. And the guideline has put this as a class 1 recommendation in patients with MINOCA. But there is a pitfall here. women with thinner myocardial walls, it is challenging to evaluate non-transmural ischemia by CMR. Then the coronary CT angiogram, as we know, we can pick up the severity and the extent of disease. It's widely available, has very high diagnostic accuracy. Of course, there are now functional components coming up when we combine CT with FFR and CT MPA. Women, because they have smaller epicardial coronary arteries, there may not be accurate assessment of distal coronary arteries. That is one pitfall of CT. In CT coronary angiogram, this is the confirmed registry where it is demonstrated that women have a higher hazard ratio for a level of CAD as compared to men. The province is the trial which randomized around 10,000 patients with stable symptoms. Over a median follow-up period of 25 months, there was no difference between testing arms in clinical events or by sex. And women were significantly less likely to have an abnormal lesion compared with a positive stress test. So when we look at the plaques, women have more lipid-rich plaques, fewer calcified lesions, plaque burden is less. That's why it is no obstruction or a minimal obstruction. And they have more positive remodeling, which is not shown on the luminal side. Although a calcium score of 0 carried a similar low risk for both men and women, women with any detectable calcium have a relatively more hazard for CVD mortality as compared to men. So for detection of coronary microvascular dysfunction, these are the techniques which are used. Of course, invasive angiography, there is no availability of acetylcholine. Even though invasive angio is done, we are not looking at the component of vasospasm. But coronary flow reserve, which is calculated by other methodologies, CFR less than 2 was the best predictor of major adverse outcome. If you look at the sensitivity and specificity, as I put it, exercise stress sensitivity is less. It's the maximum with CT coronary angiogram. But other functional studies, they have almost equal sensitivity. But the specificity in women with SPECT MPA is less compared to other modalities. What are my take-home messages? Myocardial ischemia has sex-specific differences, but there is a paradigm shift which is needed in the approach to imaging IHT in women. Better algorithms are needed for screening for microvascular dysfunction, especially in women with no obstruction or non-obstructive CAD. Newer modalities are highly specific and sensitive for the detection of ischemia with greater parity between the sexes. Selection of the optimal imaging modality for evaluation of an individual patient depends on multiple factors. Emerging techniques such as strain rate imaging, CT MPI and cardiac MRI present additional options for diagnosing ischemia and coronary microvascular dysfunction. Thanks for your attention.